एक्सटेंड की देना चाहिए।
Good morning, one and all. Topic for today's seminar is twin block. Topic are under following headings: evolution of functional appliances, history, appliance design, stages of treatment, modifications, twin block traction technique, growth risk to twin block therapy, conclusion, and references. So first, evolution of the functional appliances. Many variations in the design occur after the development of the monoblock. After that, Anderson developed appliance called activator. But the major disadvantage of these both appliances were the bulky and they are suitable for wear. So further research were carried out, and Baltar developed the Bioneter appliance, which has more wire components, so that to reduce the bulk. Further research followed by the Frankel's investigation of the Frankel appliance. He added more wire components, but main disadvantages of all these appliances are one-piece appliances. So if patient wear that appliance, the eat or speaking is not possible with that appliance. So new appliance were discovered by the Clark, which is a two-piece appliance, that is twin block. So the twin block are the simple byte block that achieve rapid functional correction of malocclusion by the transmission of favorable occlusal forces to the inclined planes that covers the posterior teeth. When it comes to history, how did it came up? Twin block is evolved in response to the clinical problem where the young patient, who is the son of Clark dental colleague, he fell down and completely luxated his upper central incisor. The age of the patient was 7 years 10 months. Because of the luxation of the upper central incisor, he came in the Angle's clinic. Angle invented a beautiful sentence: necessity is the mother of invention, which is appropriate for he suddenly came with this condition. That's why he discovered that sentence. uh, he reimplanted that luxated upper central incisor, but after 6 months of this, there is the resorption of that central incisor. This is because there is adverse lip reaction. As this patient has class 2 division 1 malocclusion, there is lip trap, and adverse lip action on the central incisor causes the resorption of that central incisor. To prevent this, it would be necessary to design the appliance that could be worn full time. So Clark discovered the simple bite blocks. He placed that bite blocks in the patient so that to separate the mandible and the maxilla, and also to prevent the lip trap and prevent the direct pressure on the upper incisor. So the first twin block appliance were fitted on the 7th September. The patient at that stage was 8 years. He corrected the distal occlusion and overjet from 9 mm to 4 mm in 9 months. So this is Clark's design of the first appliance, where the 2 mm vertical separation was done to hold the incisor out of occlusion. William Clark introduced his appliance to the world in the year 1982. What is philosophy of this appliance? There are two concepts. One is occlusal inclined plane, and second is proprioceptive concept of growth. When we consider occlusal inclined plane, it play an important role in determining the cuspal relationship of the teeth as they erupt into the occlusion. They produces the occlusal forces which transmit to the through the dentition to the supporting tissue and help in the development of the supporting structures. Occlusal inclined plane, if we consider the class 2 division 1 malocclusion, here the inclined planes are in such a way that the occlusal forces has the distal component. So the mandible occlude distally, and because of the distal component of the force, there is unfavorable growth of the mandible. So the inclined planes serve as a servo mechanism that locks the mandible in a distally occluding functional position. Second is proprioceptive stimulus of growth. If the favorable cuspal guidance is there, for example, in natural dentition, there is favorable cuspal guidance, so it produces the repetitive tactile stimulus and functional equilibrium is established by giving the constant proprioceptive stimulus to the dentition, which causes the accurate growth of the mandible and the supporting structure. But if there is a malocclusion, there is unfavorable cuspal guidance and unfavorable occlusal forces, which causes the which do not lead to the proper proprioceptive stimulus to the mandible, and hence growth of the mandible is altered. So the aim of the functional appliance therapy is to improve the functional relationship of the dentofacial structure by eliminating these unfavorable factors, and also to improve the muscle environment that envelops the developing occlusion. If we use the functional appliance therapy, it establishes a new functional behavior pattern by altering the position of the teeth and the supporting structures. So if we use twin block, there is favorable cuspal guidance because we are modifying occlusal inclined planes, and hence there is proprioceptive stimulus to the dentition, which causes the forward growth of the mandible. Comes to the appliance design, it is patient friendly appliance because of the comfort and the aesthetic of appliance, and there are two separate blocks, upper and lower, so patient can easily eat or speak with the wearing of appliance. So components of twin block, there are three components: retentive component, active component, and the passive component. In retentive component, wire parts are there: delta class, ball and class, C class. Active component involve inclined plane and the expansion screw, and passive component is labial bow. When it comes to the retentive component, delta class, which was first designed by Clark in 1985, the initial delta clasp has triangular shape, but and it is made up of the 0.7 mm stainless steel wire using the bird beak wire. But later on, this shape is modified from triangular to the circular. If the tooth is favorably shaped, this retentive loops angle to follow the curvature of the mesial and the distal undercut. But the tooth is unfavorably shaped, this loop should be directed interdentally. The area where the retentive loops will be placed, first on the upper first molars and the lower first premolars, and if the first premolars are not erupted, deciduous molars can be used for the placement of the delta clasp. So what are the advantages over the Adams clasp? It has excellent retention, reduced metal fatigue, minimal need for the adjustment, and this clasp do not open with the repeated insertion and removal. So breakage is only 1% with the delta clasp. Second is interdental ball-ended clasp, which are placed mesial to the lower canine and in the upper it should be placed between the premolars. If premolars are not there, it will be placed in the deciduous molar region. They help in the interdental retention and prevent the resistance to antero-posterior tipping. Third component is C clasp. It is used for the additional retention, and it is placed in the area of mesial to the canine and the premolars, mostly used in the mixed dentition case. Passive component, it is a first passive component involve the labial bow. Labial bow should not make contact with incisor. If it makes contact, uh, It is made from the 0.7 mm stainless steel wire. It makes contact with incisor, there is overcorrection of the incisor angulation by retracting the upper incisors, and it limits the functional correction by the mandibular advancement. Hence, in most of the cases of twin block, labial bow is contraindicated. And lip pressure is effective in uprighting the upper incisors. Hence, natural lip pressure it acts as like a labial bone. Active component involve inclined plane and the expansion screws. If you consider the angulation of the inclined plane, to measure the angulation, lower block mostly determine the angulation. The angle is designed from the second molar to the occlusal plane. This is occlusal plane, and inclined plane that uh, comes from the distal surface of the upper first molar to the medial surface of the lower molar. It acts as inclined plane drawn. This angle should be 70 degree, and the lower block not extend distally to the marginal ridge. There are three angulations. One is 90 degree, 45 degree, and the 70 degree. 90 degree angulation has more distal component, so it is difficult to maintain the forward posture, and it causes the backward movement of mandible. So there is tendency to create the posterior open bite. If the 45 angulation is there, there is equal downward and forward component of the force. And if the 70 degree angulation is there, there is more horizontal component of the force. 45 degree angulation is mostly used if the patient has severe distal occlusion or has difficulty in maintaining the forward posture. But in routine practice, 70 degree angulation is used. Buccolingually, the thickness of the inclined plane should be thinner in the lower canine region, and it should be thick in the premolar region. It should be sufficient thickness. There should be sufficient thickness in the midline so that to give the adequate strength to avoid the breakage. Uh, as it block extend distally, the thickness reduces from the premolars to the molar, and upper arch should be wider than the lower. If you consider occlusal surface, it should be flat and well polished to allow the free lateral movement of the mandible. This is how the upper and lower blocks are constructed. Next is twin block tool. It was invented by the real KFO. It offers the exact what angulation we require, whether it is 70 degree or 45 degree. So this tool is mostly used if there is a need of the accurate determination of the angulation. When it comes to bite registration, according to Woodside, the horizontally the bite should be the mandible should be protruded 3 mm distal to the most protrusive position that the patient can achieve, and vertically it should be within the limit of the freeway space. And according to Clark, if the sagittal advancement, if the overjet is up to 10 mm, there is a single advancement will be indicated, and more than 10 mm, progressive advancement, stepwise or the two-step advancement is indicated. The length of the patient's protrusive path is determined by the centric occlusion and the fully protrusion occlusion, and activation should not be exceed the 70 degree of the protrusive path. If we consider vertical dimension, it should be either slightly beyond or within the limit of the freeway space. The block should be sufficient thick so that no posturing out of the appliance will be there. This is the tool called Exacto Bite or the Project Bite gauge, which is used for taking the bite registration. It has three screw in the upper incisal portion and one screw in the lower incisal portion to guide the placement of the gauge. There should be the 2 vertical clearance between the incisal edges of the upper and the lower incisors, and the 5 to 6 clearance between the in the first premolar region. So, the summary of the bite registration: interincisal clearance should be 2 in the first premolar region, it should be 5 to 6 and in the molar region, it should be 1 to 2 The stages of the twin block treatment: there are three stages. One is active stage, uh, active phase, support phase, and the retention phase. Active phase, the duration of the active phase is 6 to 9 months, and the active phase where the posterior inclined planes are given, and trimming is mostly carried out in the active phase. Sagittal correction is achieved before the vertical, and at the end of the active phase, the overjet, overbite, and the distal occlusion should be fully corrected. If you consider the trimming of the block, in the horizontal growth, trimming of the block is indicated. It increases the facial height, and it is contraindicated in the vertical growth pattern. Active phase: for the in the first visit, the fitting of the appliance is there, and check for the clasp, labial bow, and the twin block fit. In the second visit, it is after the 10 days, clearance of the 1 to 2 1 to 2 over the lower molar to reduce the deep overbite, and check the patient biting comfortably. If not, trim the inclined planes accordingly. That third visit, after the 4 weeks, where the progress is taken, there should be reduction in the overjet, overbite, and the sagittal correction should be achieved after the fourth week, and trim block accordingly, and minor adjustment will be done at the third phase. Fourth visit, it is after the 6th week. Here also the block is trimmed to reduce the overbite, and the final corrections carried out until the 9 months. The intergingival height, it measure from the gingival margin of the upper incisor to the gingival margin of the lower incisor. It is a simple guideline to establish the correct vertical dimension, and the comfort zone for the intergingival height for the adult patient is 17 to 19 Support phase lasts for 4 to 6 months, where the anterior inclined plane is given to the patient. The aim is to maintain the correct incisal relationship until the occlusion is fully established, and it contains the upper removable appliance, which anterior inclined plane is added to the upper removable appliance with the labial bow to engage the lower incisor and the canine. Then a retention phase. Retention phase is followed using the upper anterior inclined plane appliance, and it lasts for 9 months. This is the duration of the treatment. Active phase for 6 to 9 months, support phase for 4 to 6 months, and the retention phase for the 9 months. After that, the fixed appliance phase is there, where the final detailing of the occlusion is completed by giving the fixed appliance therapy. Indications of twin block. The major indication is class 2 division 1 malocclusion, where the patient has permanent dentition, active grower, uncrowned dentition with the well developed arches, increase overjet 10 or the more than 10 and the patient should have the normal growth direction, horizontal growth. Contraindication: the twin block is contraindicated in the skeletal class 2 with maxillary prognathism, in the vertically directed grower, in the labial tipping of the lower incisors, and in the crowding cases. These are the sagittal corrections following the twin block therapy. There is increase in the SNB angle because of the forward growth of the mandible, little change in the SNA, and increase in the lower anterior facial height. Dental changes: it reduces overjet, retroclination of the upper incisors, proclination of the lower incisors, and lower molar eruption in the anterior and the superior direction. This is the article published in the AGODO in 1998, Treatment Effects of the Twin Block Appliance, where they concluded that the mandibular length after the twin block appliance is increased 6.5 in the case as compared to the control group. SNB angle is increased, SN angle is slightly reduced, and there is uprighting effect on the upper incisors and the labial tipping of the lower incisors. Growth response to twin block treatment. Because of the forward position of the condyle, there is activation of the superior head of the lateral pterygoid muscle, which causes elicitation of the stress reflex in the lateral pterygoid muscle, which pulls the articular disc. Pterygoid response when within the few days of the fitting the twin block appliance, the position of the muscle balance is altered so greatly that the patient feels pain when he retract mandible. This is called pterygoid response. Uh, According to the Harvard and Wood side, there is development of the tension zone when the mandible postures downward and forward. There is immense cellular activity at the condyle, and this area is further replaced by the proliferation of the connective tissue, which act as the tension zone. This is the article functional determinants of the craniofacial size and shape, uh, where they given this sequence when the mandible posture forward and downward, no vacuum is created behind the condyle. So there is proliferation of the functions are usually carried out while wearing this appliance. When it comes to the limitations, patient's cooperation is needed as it is a removable appliance. It is impossible to wear the full time 24 hours, and it is also age dependent. Also, it causes the loss of proprioceptive stimulus when patient try to back the mandible backward. This article, incremental versus maximum bite advancement during the twin block therapy, published in the AGODO in 2004. This article concluded that whether the twin block had been advanced with maximum or the incremental advancement, it did not influence any outcome variable. There are two variables. One is the operator and the initial overjet, but there is this appears to be that there is no advantage of using the incremental bite advancement in the twin block therapy. This article published in the APOS Trends in Orthodontic in 2016, versatile twin block design for the non-compliance class 2 correction. This article was published by Herschel sir and Bird ma'am. In this study, they did the design of the semi-fixed twin block appliance. The procedure for this is first the upper and permanent molars are banded, and the lingual sheath is attached vertically over the band, and pickup is taken. After that, the wire 20 gauge wire is used to make a double back, and the open end of the wire should be such that it should incorporate in the block. Bite registration is taken and block is made so that it incorporates the open end of the wire. Lower block is made as we made normally in the conventional appliance, either using the clasp or without clasp, and the lower block is cemented, and if we require the trimming of the block, only the upper block is removed and trim accordingly and then fixed, so it is act as a semi fixed appliance. These are the results after the treatment. If we consider the modifications of twin block, it includes modifications in the mixed dentition, modifications for the arch transverse development, modifications for the sagittal development, and to close the anterior open mouth. In mixed dentition, mostly the C clasp is used for the additional retention. These are the C clasp used for the mixed dentition patients. For the transverse development, the screw is incorporated in the upper and lower bite block to develop the to cause the more transverse expansion of the maxillary and the mandibular arch. This appliance was designed by Shaw, who combined the twin block with the expansion screw. Second is twin block crochet appliance, where the transpalatal arch and the lingual arch is given in the patient along with the twin block, and also the hooks are placed in at the molar band. This appliance is used for the adult patient. For sagittal development, it is mostly indicated in the class 2 division 2 malocclusion to increase the arch length and to advance the retrocline incisors. So the in sagittal development, addition of two screw sagittally so that there should be the anterior posterior arch expansion instead of transverse. uh, then three screw upper sagittal appliance where they combine the transverse and the sagittal expansion screws. Two screw placed sagittally and one screw in the midline so that there is expansion of the transverse in the transverse and the sagittal direction. Second is McNamara and Mills design. Here they use two expansion screw, one in the anterior region in the premolar region and the second in the molar region, and the labial bow with the acrylic anterior to the lower incisors also used to keep the lower lip away from the appliance. And the two screw should be adjusted accordingly whether we want anterior or the posterior expansion. Then the occlusive guide appliance is there. It is also called preform mini positioner appliance. Also, it acts as the functional retainer uh, between the during the transition from the mixed to the permanent dentition. If the patient has class 2 division 1 malocclusion, the bite registration is modified. The age to age occlusion should be considered instead of more advancement and more modifications for the class 3 malocclusions. Here, the in class 3 malocclusion, reverse twin block is used to encourage the maxillary development by the action of the reverse occlusal inclined plane, which is cut at the 70-degree angle. And this angle should be with the upper inclined plane. In normally, it should be with the lower block beside the angulation. In reverse twin block, upper block beside the angulation. Modifications for the class 3 patient who has difficulty in achieving age to age occlusion. In these cases, the maxillary protraction appliance is given along with the reverse twin block so that to protract the maxilla. This article published in the Progress in Orthodontic in 2019, effectiveness of the reverse twin block with the lip pad RME and the face mask with RME in the early treatment of the class 3 malocclusion. Here the three groups are used, one with the reverse twin block with lip pad RME, one with the face mask with RME, and third is control group. The conclusion, both groups were effective in correcting the malocclusion, but the reverse twin block lip pad RME appliance had not significant, but the greater impact on the maxillary advancement and more hold on the posterior positioning of the mandible with the minimal dental compensation as compared to the face mask RME group. Additional modifications, lip pad may be added to the twin block to enhance the forward movement of the upper labial segment. The action of this appliance is similar to the Frankel 3 appliance. This article published in the journal in 2011, a simple method for the twin block reactivation. In this, they use a standard jack screw with the modified with the self-cure acrylic, where they place the block. Lower acrylic block was made, and in the upper block, expansion screw is added such that this one end is fixed in the upper block and other end remains open, so that when we activate the screw, there should be the expansion in the sagittal direction to advance more mandible. For class 2, the screw is placed in the upper block. If the class 3 malocclusion is there, screw is placed in the lower block. Advantage of this technique is it is accurate, measurable advancement either bilaterally or unilaterally, and no need for the special screw. Normal jack screw is placed, and there is ease of adjustment at the chair. Treatment of the anterior open bite and the vertical grower pattern. No trimming is indicated when the patient is vertical grower, and Also avoid the over eruption of the second molars behind the appliance, so that the mandible should not uh, goes downward, and there should not be the tendency to lead the open bite. To correct the anterior open bite, intraoral traction may be used. This method was given by Dr. Christian Mills. They use the accelerated. They use running vertical elastics from upper to the lower premolar, so that to close the open bite simultaneously with the twin block. Magnetic twin blocks. To accelerate the arch corrections, mostly the two rare earth elements, that is samarium cobalt and neodymium boron, are used in this technique. This technique encourages the increased occlusal contact on the bite block to maximize the favorable functional forces. Two types of magnets are there. Attracting magnets, they attract the attracting magnet pulls the appliance together and encourage the patient to occlude actively and consistently in the forward position, and the repelling magnets apply the additional stimulus to the forward posture of the jaw. Temporary fixation of the twin block. Twin block is either fixated by using the cement, that is zinc phosphate or the zinc oxide cement, or it second method is to bond directly to the tooth by applying the composite around the ball and clasp. Next is twin block traction technique. In the early stages of development, the twin block technique method has devised to combine the functional therapy and the orthopedic traction. This is mostly indicated in the maxillary retrographic patient. The concoror phasebow is used so that to protract so that to retract the mandible along with the protraction of the mandible. Here is the design of the concord phasebow. They use the intermaxillary elastic to attach to the lower block, so there is simultaneous retraction of the maxilla and the protraction of the mandible. Twin block and the airway. This article is published in the 2021 evaluation and quantification of the airway changes in the class 2 division 1 patient undergoing the myofunctional therapy using the twin block appliance. The aim of this article was to determine the airway changes in the skeletal class 2 division 1 malocclusion patient with the mandibular retrognatism treated with the twin block. The result of this articles are: twin block appliance increases the mean airway area by 2.28 plus or minus 2.25 centimeter square, and this twin block appliance therapy has positive effect on the upper airway and is beneficial for the treatment of the sleep related disorders associated with the class 2 division 1 malocclusion for achieving the positive functional changes, aesthetic and the healthier quality of life. Treatment. This is article published in the 2000 treatment timing for the twin block therapy. This is the cephalometric study who compared the skeletal and the dentoalveolar changes induced by the twin block appliance in the class 2 patient. Two groups are there which are at the different stages. First group involves the 9-year 11 months patient. Second group involves 12-year 11 months patient. And the finding of this study indicate that the optimal timing for the twin block therapy is during or slightly after the onset of the pubertal peak in the growth velocity. When compared with the treatment performed before the peak, late twin block treatment produces the more favorable effect that include the greater skeletal contribution to the molar correction, larger increment in total mandibular length and in ramus height, and the more posterior direction of the condylar growth leads to the enhanced mandibular lengthening to reduce the forward displacement of condyle in favor to the effective skeletal changes. This is article published in 2001, localization of the mandibular changes in patient with class 2 division 1 malocclusion treated with the twin block appliance. It is a finite element scaling analysis. This article concluded that the localization of growth in the condylar neck with concomitant remodeling of the coronary process may reflect the correction of the mandibular form achieved with the twin block appliance. Twin block therapy may involve the developmental modulation at the condylar cartilage, modeling of the ramus and corpus, and osteogenic deposition in the dentoalveolar region. This article, Muscle Response to the Twin Block Appliance, electromyographic study of the masseter and the anterior temporal muscle. This article concluded that a definite muscle response for the anterior temporalis and masseter muscle to the twin block functional appliance was observed to be more pronounced, and the mean masseter activity during postural position increased significantly. The most significant change occur in the electromyographic activity of the masseter muscle during maximal voluntary clenching, which increased from the start to the end of 6 months. To conclude the seminar, face the fact that functional appliances create aesthetic faces and the fixed functional mechanotherapy correct teeth. So, if we want to treat the face, we should use a functional appliance first instead of the fixed mechanotherapy. These are my references.